for behavioral science, and you finish this course. Okay, let me start with the presentation. Can see the presentation, right?
Yes.
Okay, very good. Okay, so today we have a few brief topics. It's about the biological assessment of patient with psychiatric symptoms. Um, it is also about the neuropsychological tests and psychiatric disorders in children. So, biological assessment of people with the psychiatric disorders, it is necessary to determine a different chemicals in the brain and in the blood, because sometimes some psychiatric disorders associated with altered levels of different neurochemicals. For example, altered levels of bioorganic amines and their metabolites occur in some psychiatric conditions. Bioorganic amines are um, the same as serotonin, dopamine, and norepinephrine. So the general term of these neurotransmitters are bioorganic amines. Structurally, they resemble bioorganic amines. And we also measure the plasma levels of some antipsychotics and antidepressants to evaluate the compliance of patients, because it is necessary to determine if the patient is taking a medication to determine the outcome of the treatment, right? And also we need to by measuring antipsychotic and antidepressant drug, we are trying to determine the therapeutic blood levels of the medication. So this information give us the prediction of the outcome of the different disorders. We also need to do a lab tests to monitor patients for complications of pharmacotherapy, because lots of drugs that are used in the in psychiatric patients in behavioral medicine might have the side effects. For example, patients who are taking the mood stabilizers we are just prescribing mood stabilizers for MDD or bipolar disorder, right? So these mood stabilizers like carbamazepine or antipsychotics that we are using during schizophrenia or different psychotic disorders might have side effects like blood abnormalities or agranulocytosis. So we need to do a blood test to determine the side effect of a drug. If we have this agranulocytosis, we need to change the treatment. So that's why it is important to understand why we are doing the lab tests during the treatment of psychiatric disorders. Also, we need to do a liver function tests because when the patients are treated by the mood stabilizers, by carbamazepine or by valproic acid, they might influence on the liver function and alter the liver function, and that's why we need to determine this by the liver function tests. Thyroid function and kidney function tests also should be used in patients. who are treated by the mood stabilizer lithium. Lithium is the very effective mood stabilizer, but very toxic. So it influences on kidney function and thyroid function, and the lithium can impair the kidney function and the thyroid function. And because of the lithium, patient might develop the hypothyroidism, and eventually hypothyroidism can turn to the hyperthyroidism because of the using of the lithium. And also, the lithium levels should be monitored regularly because it has a narrow therapeutic range. It means that it is very toxic. So, because of that, lithium should be monitored regularly in the blood, not to allow to become toxic for the organism. So, but lithium is known as the most effective mood stabilizer in treating the bipolar disorder and different disorders with some manic states.
Hello, doctor.
Yes.
Hi, can I ask you a question, please?
Sure.
The midterm, I just wanted to clarify the topics covered.
Mm-hmm.
You said it will be lectures 1 to 7.
Mm-hmm.
So I just wanted to confirm the PowerPoint. So the first one is the introduction, and then we have genetics.
I will tell you on what topics you have to focus more. You have to focus more on substance use disorders, sleep disorders, uh, uh, schizophrenia,
Yeah.
bipolar disorder. Mainly these topics are included into the first midterm. I told you that the second midterm will be simple. So mainly these four topics are you have to focus on. Okay.
So we have from the PowerPoint, we have substance-related disorders, sleep,
Mm-hmm.
schizophrenia, and other psychological disorders.
Mm-hmm. But I recommend you to read the book, guys,
Yeah.
because the questions are mainly focused and based on the book information. But the PowerPoint presentations is also built up according to the book. So you might use the PowerPoint presentation and some additional material you can just check from the book. It is also a very short book, so I don't think that you need it takes a lot of time to read that book. So mainly focus on these topics: sleep disorders, substance use disorders, schizophrenia, uh, mood disorders, mainly these.
Okay, doctor. Thank you.
Yeah. Yes, so don't worry, it won't be difficult.
No problem.
Okay, when we are evaluating the endocrine function, we might use the dexamethasone suppression test. So we are using this test when we have the major depressive disorder. It is not a specific test for other disorders, but for major depressive disorder, we can use this dexamethasone suppression test to identify this disorder in a patient. In normal patient with a normal hypothalamic adrenal pituitary axis, this test suppresses the secretion of the cortisol. You know, cortisol is a hormone, right? But in a major depressive disorder, this test is positive, so it means that suppression is limited or absent. So by this test, we can identify that the person might have the major depressive disorder. But as I told you, this test is very limited because it is not specific for other disorders, and we can only use the dexamethasone suppression test for major depressive disorder to identify this disorder in patients. Thyroid function tests also used to screen for the hypothyroidism or hyperthyroidism, which can mimic the depression and anxiety, because people with a thyroid dysfunction might have associated depression and anxiety. And to exclude the primary depression, we have to do the thyroid function test. And then we will know that if there is a hypothyroidism or hyperthyroidism, depression is secondary to this problem. Physical symptoms of hypothyroidism include fatigue, weight gain, edema, hair loss, and cold intolerance. And physical symptoms of hyperthyroidism include rapid heartbeat or palpitation, flushing, fever, weight loss, and diarrhea. Uh, Patients with a depression might have the different endocrine dysfunctions, endocrine irregularities, such as um, abnormalities in the growth hormone, abnormalities in melatonin levels, in gonadotropin levels. So because we know that depression itself is irregularities in some specific neurotransmitters, and we know that if one neurochemical is changing and we have abnormal levels of one neurochemical, it also affects different systems, and the different abnormalities occur during the depression. So these endocrine irregularities also might occur during the depression. The abnormalities in growth hormone, melatonin, and gonadotropin. Why melatonin? I will explain you that we have serotonin. Serotonin is the major neurotransmitter to regulate the mood. So serotonin is a precursor of the melatonin. So if there is irregularities in serotonin levels, automatically it affects the melatonin levels also. And plus, gonadotropin irregularities might also occur. Um, there are some other endocrine disorders which might have psychiatric symptoms, associated psychiatric symptoms. And these endocrine system disorders are Addison disease or hypercortisolism, Cushing disease, hypercortisolism, and enzyme disorders such as acute intermittent porphyria. So what are the characteristic signs of Addison disease? The physical signs and symptoms are hyperpigmentation of the skin. In particular, this hyperpigmentation occurs in skin creases, low blood pressure, pain, fainting, hypoglycemia, diarrhea, and vomiting. These are physical signs. And we are more interested in psychiatric symptoms because our field is psychiatry or behavioral science. These two are French sciences, and we are more interested in these symptoms of the endocrine disease. These psychiatric symptoms might include fatigue, depression, even psychosis, and the confusion. So, for example, if you get the patient with these psychiatric symptoms, of course, we need to exclude the endocrine disorders. And if we know that there exist some endocrine disorders which might have these psychiatric symptoms, we need to first exclude the medical conditions which might give us these psychiatric symptoms, and then turn to other treatment options and evaluations of the patient. Another type of endocrine system disorder is a Cushing syndrome, which also has the psychiatric symptoms. But first, I want to mention the physical signs. Physical symptoms are the specific characteristic sign is the round moon face during Cushing syndrome. bruising, purple stria on the skin, sweating, facial hair, hypertension, and another specific sign of Cushing syndrome is fat on the back of the neck or buffalo hump. And the dexamethasone test is positive in the Cushing syndrome also. The psychiatric symptoms associated to this disorder is elevated mood, psychosis, anxiety, and depression. So sometimes we can be messed up with a bipolar disorder. If the patient might have the Cushing syndrome, but might have the manic state at the same time. So we need to differentiate between the bipolar disorder and the Cushing syndrome. Of course, we have to exclude Cushing syndrome and then turn to the bipolar disorder, because symptoms are similar in the Cushing syndrome and the bipolar. Acute intermittent porphyria. The physical signs and symptoms include abdominal cramp, diarrhea, vomiting, seizures, cardiac arrhythmias, flushing, purple discoloration of urine due to the elevated porphobilinogen. This is an enzyme which is increased during the acute intermittent porphyria. And of course, psychiatric symptoms are associated with this endocrine enzyme disorder, which include the paranoid delusions and hallucinations, as well as depression and anxiety. So here we might have problem in differentiating between the acute intermittent porphyria and the schizophrenia, especially paranoid type of schizophrenia. So symptoms of acute intermittent porphyria, psychiatric symptoms, similar to paranoid schizophrenia. So of course, first of all, we have to exclude this disorder to then differentiate that is this acute intermittent porphyria or schizophrenia. Okay. Now, what type of measurement we are using to differentiate different psychiatric symptoms and behavioral disorders? We know that some structural abnormalities might be associated with specific behavioral disorders. For example, during schizophrenia, we have some structural changes, and we may see these structural brain changes via the neuroimaging or EEG studies. So we are using different neuroimaging studies to identify the different structural changes in the brain which are specific to different behavioral disorders. For example, computed tomography or the CT scan identifies anatomically based brain changes, for example, enlarged brain ventricles, which is seen in disorders such as Alzheimer's disease and the schizophrenia. So that's why we need the CT scan. For example, if we have some doubt about the schizophrenia, we can confirm our prediction by using the CT scan. And if we see their enlarged ventricles via the CT scan, our diagnosis of the schizophrenia can become confirmed by the CT scan. Another type of the neuroimaging studies that we are using to identify the behavioral disorders and conditions is the NMRI or nuclear magnetic resonance imaging, which identifies the demyelinating disease such as multiple sclerosis. And it also shows the biochemical conditions of the neural tissues. Okay. And when we identify this biochemical condition of the neural tissue, we can predict different mental disorders. And of course, when we can predict the different mental disorders, we can prevent these disorders. That's why it is very important to have these neuroimaging studies, the data from these neuroimaging studies. Another type of the neuroimaging is a PET scan or the functional MRI, which localizes the areas of the brain that are physiologically active during the specific tasks. And also it's measuring the metabolism of glucose in neural tissue. So you know that when the neural tissue is active, it absorbs glucose. And the more the neural tissue is active, it absorbs more glucose. So by measuring the levels of the glucose, we can identify how active the neural tissue is. And also the PET scan and fMRI measures the specific neurotransmitter receptors. So it is also very informative for the psychiatry practice and behavioral science, because when we are measure the condition of the specific neurotransmitter receptors, we can identify and predict the different mental disorders. Another type of the neuroimaging is a single photon emission tomography, or the SPECT scan, and it obtains the similar data to PET and fMRI, but the difference is that during PET and fMRI we are using the cyclotron, and here it is used a standard gamma camera. It is simpler to use the gamma camera than to use the cyclotron. That's the only difference, but the data with the SPECT scan are similar to the PET scan and fMRI. EEG, or electroencephalogram, measures electrical activity of the cortex, which is very important in diagnosing an epilepsy or dementia. And also we might measure the alpha waves, theta and delta waves during the schizophrenia, because we know that there is a specific characteristic of brain waves during the schizophrenia. We know that there is a decreased alpha waves and increased theta and delta waves during schizophrenia, and EEG will show us these characteristics. So also this is also very informative measurement procedure to identify the schizophrenia. Evoked EEG, or evoked potentials, measures the electrical activity in the cortex in response to tactile, visual, or auditory stimulation, and it is used to evaluate the vision and hearing loss in infants and brain responses in comatose or suspected brain dead patients. So this is another type of the measurement procedures. These are the major neuroimaging imaging strategies to evaluate the biological responses of the psychiatric patients. Besides the neuroimaging studies, we are using the neuropsychological tests to evaluate the condition of the different conditions of the psychiatric patients. By the neuropsychological tests, we are assessing the general intelligence, memory, reasoning, orientation, language function, attention, concentration. And these neuropsychological tests are mainly evaluated patients with dementia, brain damage, schizophrenia, In such patients, the more specific tests that we are using are Folstein mini mental state examination, which is designed to follow the improvement or deterioration in the cognitive functions. So we can apply this Folstein mini mental state to patients with a dementia or other cognitive disabilities, even with the schizophrenia, because we know that during the schizophrenia we have also cognitive impairment. And another type of test that we are using is a Glasgow Coma Scale, which is designed to assess the level of consciousness. Here you can see the different tests that are used in psychiatry. Each test is specific to the it is very specific to different psychiatric disorders. For example, Halsted rate and battery. It is identified the brain lesion localization and effects. Lurie, Nebraska neuropsychological test identifies the cerebral dominance, types of brain dysfunction such as dyslexia. Bender Visual Motor Gestalt Test identifies the visual and motor ability through the reproduction of the different designs. Digit symbol substitution, it is identifies the person with dementia, depression, and age-related cognitive decline. Boston naming test, it is applied to patients with dementia. Wisconsin card sort of test applied for identifying the executive function. Folstein mini mental state, as I already mentioned, for delirium and dementia, and Glasgow Coma Scale for identifying the level of consciousness. So now I would like to give you an example of Folstein mini mental state examination. What we are measuring by this mini mental state examination, we are measuring the skill by giving instructions to a patient, and of course we are giving the maximum score. For example, the different skills are evaluated by this mental state. For example, orientation. And to identify the orientation, we can just give an instruction like this. Tell me where you are and what day it is. And of course, after the answer, we should evaluate the person by the score. And the maximum score that we will give to the patient if he or she answers properly, it's 10. Language, it is the same. The patient should name the object that the interviewer just holding, and the maximum score is 8. Attention and concentration, registration, recall, and construction. It is the same instructions we are giving to patient, and we are giving the maximum score if we get the proper answer. And then, of course, we are summarizing the scores to identify the condition of the patient, in what condition the patient is. Is there a dementia, or is the patient having healthy cognitive functions? There exist other tests to identify the different functions of the patients. For example, one test is a drug-assisted interview. For example, we may administer a sedative such as amobarbital sodium, or it is called also an amytal interview, prior to the clinical interview, and it will be useful to determine whether organic pathology is responsible for the symptomatology or the patient is malingering, because sometimes people are malingering the symptoms of the disorder to, for example, get some medical care, and to differentiate is there a real organic symptomatology or the patient is malingering, we can just do this amobarbital test. Also, we may use the sedatives to relax patients with conditions such as dissociative disorders, conversion disorders, uh, or patients with high level of anxiety to mute the psychotic states. And these tests, these sedative tests, will allow patients to express themselves more coherently during the interview. Because if the patient has a dissociative disorder or conversion disorder or, for example, anxiety disorder, these emotional states and hyper excitement via the anxiety the patient is dysphoric, these emotions will interfere with the interview, and there might not be a coherent answers, and doctor cannot identify the objective problem of the patient. That's why we need to relax first the patient and then just do the further test to identify the real problem. Sodium lactate administration. Intravenous administration of sodium lactate also can provoke the panic attacks in susceptible patients, and this will help to identify the individuals with a panic disorder. So this is to identification of the panic disorder, this test. Inhalation of carbon dioxide also can produce the same panic attacks, and we also can use this test to identify the panic attack and phobia in the patient with an anxiety disorder. You know, the panic attack is the part of the anxiety disorder. Galvanic skin response is part of the lie detector test. As you know, lie detector test was widely used, but nowadays it is not used as frequently as it was used before, because there are some limitations of this test. What is the nature of this galvanic skin response? The electric resistance of skin or galvanic skin response varies with patients' psychological states. So higher sweat gland activity is seen with sympathetic nervous system arousal. When a person is lying, the sympathetic system of the lying person is aroused. So it results in decreased skin resistance and the positive tests. But sometimes even innocent people are anxious because they know that they are not lying, and they are anxious because they need to do this galvanic skin response. So they might give us the same result as during the person who is lying. Right? The innocent people can also be anxious, and this will give us false positive result. So that's why it is limited, that even innocent people can be anxious due to just even the person is innocent and others are blaming him or her in something, the person might be anxious. So these galvanic tests can give us the positive result, which will be the false positive in case of the innocent person, and that's why it is a limited test. And sometimes guilty people who are just very professional in lying can just lie the lie detectors. So that's why it is a limited test nowadays. Now I would like to switch to the physician-patient relationship topic, or doctor-patient relationship topic, because it is also important. a very important topic during the establishing the rapport between the patient and the doctor, because the good rapport and trustworthy relationship is giving you a better result in the treatment of this patient. The more the patient trusts to the doctor, the better the compliance of the patient to the treatment option, and the better the outcome of the disease. So, patient behavior, when the patient is sick or ill, and their expectation of physicians are influenced by their culture, by previous experiences with medical care, with doctors, with physical and mental conditions, the personality styles, and the coping skills. So all these factors we should take into account when we are we doctor trying to establish the trustworthy relationship with the patient. Only 1/3 of people worldwide with clinical symptoms seek medical care. Most people just struggling with illnesses at home, with over-the-counter medications and home management, because maybe they do not trust the doctors, or they prefer to treat themselves. So this might be a problem, for the healthcare system. Well, a person assumes a particular role in the society, and certain behavioral patterns occurs when the person is ill or sick. The sick role includes the exemption from the usual responsibilities and expectation of care by others. And The patient should work toward becoming healthy and cooperating with healthcare personnel in getting well. This is a sick role. So the critics of the sick role theory argue that it applies only to the middle class patient with acute physical illness, and emphasizes the power of the physician, and undervalues the individual social support network in getting well. Well, as to me, I think that the power of physician is crucial in the treatment of the patient. Of course, the social support network can be very useful to support sick patient, but of course the social support network cannot heal the patient, and I think that the physician is the one who should treat the person in combination with the supportive therapies from the social support networks, of course. So when we are dealing with a diseased patient, there is a problem how to tell the truth to the patient. So or how to manifest the diagnosis to the patient. This is a problem, and this problem varies from country to country, from culture to culture, and of course doctors should take into account the patient's psychological profile to tell him or her the complete truth or partial truth. So we need to take into account different factors. But for example, in the United States, adult patients generally are told the complete truth about the diagnosis, the management and its side effects, and the prognosis of their illness. This is the specific of the United States. But of course, in other countries, for example, in Georgia, it is not like that. Some patients, for example, if the patient is having a cancer, they prefer not to know the real diagnosis. But of course, they have right to know their diagnosis. But some patients prefer not to know. this is kind of defense mechanism of the person to avoid this very shocking information about the health issue. But in the United States, it's different, you know. And of course, doctors shouldn't falsely reassuring or patronizing the patient with the following statements in response of the patient, like, do not worry, we will take good care of you. You still have one child in case of miscarriage. We shouldn't do and just give these false promises to the patient. Of course, it's better to tell the truth about their diagnosis, to educate the patients about their diagnosis, the outcome, the risk, and the prognosis of their illness. But as I told you, it depends on a country, on the culture of the nation, on a psychological profile of the individual patient. And the doctors should be very delicate with informing the patient about the diagnosis. Uh, uh, some special situations can occur during the treatment of the patient. Sometimes patients are afraid to ask questions about the issues that are embarrassing, for example, about the sexual problems, or fear-provoking questions like lab results. And a physician shouldn't try to guess what is troubling a patient. It is the physician's responsibility to ask about such issues in an open-ended fashion and address them fully with the patient. And physicians are having the primary responsibility for dealing with adherence issues, as well as with angry, seductive, or complaining behavior by their patients. So physicians is taking responsibility for all these issues. What does it mean, adherence? Adherence refers to extent to which a patient follows the recommendation of the physician. Adherence is responsible for the compliance of the patient. So this adherence refers to taking medications on schedule, having a needed medical test or surgical procedure, and following the direction for changes in lifestyle, such as diet or exercise. This is an adherence, and the physician is responsible for these adherence issues. So, what are the patient characteristics associated with the adherence? Patient might have unconscious transference reaction to their physician, which might based on the childhood parent-child relationship. And this can increase or decrease adherence. For example, if the patient likes doctor, the adherence might increase. If the patient do not like the doctor, adherence is decreased. Only about 1/3 of patients adhere fully to the management recommendation, 1/3 adhere partially, and 1/3 do not adhere to such recommendation. And all these adherent issues from the patient is related to the unconscious transference phenomenon to the doctor. How much the patient likes the doctor. Adherence depends on this. So that's why it is important to build the trustworthy relationship and to establish a good rapport with the patient. And adherence is not related to the patient intelligence, education, sex, religion, race, socioeconomical status, or marital status. So as I mentioned, adherence is most closely related to how well the patient likes the doctor, or how much the patient likes the doctor. Of course, very important in establishing the good relationship with the patient is the good clinical interview. So, good clinical interview depends on good communication skills of the doctor. And the patient adherence with medical advice detection of both physical and physiological patient and patient satisfaction with the physician are improved by good physician-patient communication. So if the doctor has a good communication skills, this patient adherence will increase. Um, so, well, what is important for the doctors? What type of communication skills is important to establish a good relationship with the patient? First of all, the physical settings for the interview should be as private as possible. Ideally, there shouldn't be any obstacles between the doctor and the patient, and there must be an communication at eye level. Both patient and doctor should be seated and the communication should be at the eye level. There should be a very good eye contact because eye contact determines the relationship between the doctor and the patient, because if there is a good eye contact, it means for the patient that the doctor is involved in his problem or her problem and is very attentive to the and very involved to the process with the patient. During the interview, the physician must first establish trust and rapport with the patient, and then gather the physical, psychological, or social information to identify the patient problem. This is a primary thing to establish good, trustworthy relationship with the patient, and then, of course, gather the information. And of course, finally, the physician should try to educate the patient about the illness and motivate the patient to adhere the management recommendation. And the more the patient is informed about the illness, the more the more informed the patient is, the more chance is for the better adherence and for the better outcome of the disease from the side of the patient. In case if the patient is dangerous, of course, physicians should obtain backup or hospital security, especially if the doctor is dealing with a psychiatric patient. The patient might be dangerous, and of course, physicians should obtain the backup or hospital security. The interview serves to obtain the patient's psychiatric history, including information about the prior mental problems, drug and alcohol use, sexual activity, current living situation, and the sources of stress. All these factors we should take into account, and we should gather this information during the interview to establish and determine further treatment plan of this particular patient. This interview is with the adult, and also the doctors who are interviewing the children. They should have the specific attitude to children, because children are having a different psychology than adults, and they need some specific techniques to establish the trustworthy relationships. So doctors, when they are interviewing the young children, should establish rapport by interacting with the child in the non-medical way, for example, drawing pictures, and they should just use the direct open-ended questions. For example, what is your sister name, rather than tell me about your family, because children, they are children, they just cannot identify these type of questions. What you want, I mean, doctors want to get information from the children, right? So they rather, they better used with children open-ended question, just rather than these type of questions. And they should ask questions in the third person. For example, why do you think that the little boy in this picture is sad? Then like from the then like ask questions from the first person. And of course, there are specific interview techniques the doctor should use: direct questions and open-ended questions. It depends on the situations. Direct questions are used to elicit a specific information quickly from patient in an emergency situations. There is no time for open-ended questions in an emergency or urgent situations. In this case, we should use the direct questions. For example, have you been shot? Or when, and also we can use the direct questions when the patient is too much talkative or is seductive. Direct questions, of course, good to elicit information quickly, but open-ended types of questions are more likely to aid in obtaining information about the patient and not close of potential areas of the pertinent information. So open-ended types of questions give us more information than the direct questions. But of course, it depends on the situation. In an emergency situation, it's better to ask the direct questions. And using the open-ended questions like what brings you in today, the doctors gives little structure to patient and encourages the patient to speak freely. The more structured is the questions, or if you give the more structure to the patient, the less information you will get from the patient. So this type of questions encourages the patient to give you more information with less structure. Next topic is about the psychiatric disorders in children. Psychiatric disorders in children mainly are pervasive developmental disorders of childhood. So what is included in pervasive developmental disorders? Mainly autistic disorder, Asperger disorder, Rett disorder, and childhood disintegrative disorder. These are the major pervasive developmental disorders which are included in the child psychiatric disorders. And of course, the ADHD, Tourette disorder, and elimination disorders. These are also psychiatric disorders that are included in this section. So, pervasive developmental disorders are characterized by the failure to acquire or early loss of social skills and difficulties with language, which results in lifelong problems in social and occupational functioning. So these disorders are irreversible, or they aren't reversible, and the management of these disorders involves mainly the behavioral therapy to increase the social and communicative skills and decrease the behavioral problems like self-injury. Behavioral techniques which are used to treat the pervasive developmental disorders improve the self-care skills, and also we might use the supportive therapy and counseling or family therapy to increase the social skills of the parents of kids with the pervasive developmental disorders. But the major intervention with kids with pervasive developmental disorders are behavioral techniques, and especially ABA therapy, applied behavioral analysis, which is the evidence-based method to treat and to modify the behavior of the pervasive developmental disorders. So, autism spectrum disorder, it is a very severe disorder, and the characteristic of autism spectrum disorder is a significant problems with the communication. The child has a normal hearing, but have significant problem with the communication, because we have. I'd like to explain that there is a problem with the left hemisphere, which is responsible for the communication. Left hemisphere is impaired. That's why the child, despite normal hearing, has problem with communication. There is a significant problem forming social relationship, including those with caregivers. If there is a problem with the communication, of course, there logically is the problems with the forming social relationship. They have a very restricted range of interest. They do not play the imaginative games. There is a problem with meaning. These kids with autism spectrum disorder cannot understand the meaning of the concept, so they cannot play imaginative games. They have repetitive, purposeless behavior like spinning or self-injury, and their intelligence is below normal, like 25-75%. And in some autistic kids, we might even observe the unusual abilities like exceptional memory or calculation skills. These type of autistic kids we call the savant kids, or kids with savant skills, with exceptional memory or calculation skills. But this is a very rare type of skills that occur in the autism spectrum disorder. This is a very severe type of disorder. Another type of autistic spectrum disorder, but the mild version, is Asperger disorder. It is a mild form of ACD, which involves the significant problems forming social relationship, repetitive behavior, and intense interest in obscure subjects like models of 1940s farm tractors. But if we compare autistic spectrum disorder with Asperger disorder, there is a difference between these two disorders. In autistic spectrum disorder, we have the developmental language delay. In Asperger disorder, there is no developmental language delay. However, the conversational language skills are often impaired in Asperger disorder also. So this is a mild form of ACD. So ACD occurs in about 13 children per 10,000, but this statistics is changing over the year, and this disorder, like autistic spectrum disorder, became more frequent nowadays. No one knows what is the real reason of this ACD. There is an idea that multiple genes are involved in manifestation of this disorder, and there is no one gene which is identified to which is responsible for this disorder, and the multiple genes are involved in this disorder. So the ACD begins before the age of 3, and this is specific for boys. Boys are 5 or 4 times more prone to have this disorder than the girls. So there are some abnormalities in neurobiology, which is associated with the etiology of the ACD, and these abnormalities are cerebral dysfunction. 25% of kids develop seizures because of the cerebral dysfunctions. There is a history of perinatal complications. Of course, there is a genetic component, as I already mentioned. There is an evidence of total brain and amygdala overgrowth during the first few years of life. There is abnormalities in hippocampus. There's a fewer Purkinje cells in the cerebellum, and there is less circulating oxytocin and dysregulation of serotonin synthesis in the ACD kids. These are the abnormalities in neurobiological etiology of the ACD. Rett disorder. Rett disorder is a type of the ACD, but Rett disorder characterizes more girls than the boys. So we have the similar symptom in the Rett disorder: diminished social, verbal, and cognitive development after up to 4 years of normal functioning. The kid might function normally 4 years of life, and then abruptly decreasing the cognitive, verbal, and social development. So as I mentioned, Rett disorder occurs in girls, and because Rett disorder is X chromosome linked, specifically XQ28 chromosome is impaired. Now, Rett disorder has the same stereotype and hand wringing movements, ataxia. They might have breathing problems and mental retardation. Childhood disintegrative disorder involves diminished social, verbal, and cognitive and motor development after at least 2 years of normal functioning, and also there is a mental retardation. So these disorders, these pervasive developmental disorders, symptomatically resembles each other, so they have similar symptomatology. That's why they are included in this general disorder, pervasive developmental disorder. Another type of the childhood psychiatric disorder is ADHD, or attention deficit hyperactivity disorder, and disruptive behavior disorder. Well, attention deficit hyperactivity disorder and disruptive behavior disorders include conduct disorder and oppositional defiant disorder that are characterized with inappropriate behavior that causes difficulties in social relationship and school performance. So in these disorders, there is no clear mental retardation, and these disorders are common disorders. And differential diagnosis of these disorders can be done with the mood disorders and anxiety disorders. So if the behavioral abnormalities occur only in one setting, for example, only at home or only at school, we can't diagnose the ADHD or disruptive behavior disorders. So behavioral abnormalities should exist in at least 2 settings, at school and at home, to establish this diagnosis. So etiology of the ADHD and disruptive behavioral disorders. The genetic factors, of course, involved in the etiology of ADHD. If the relatives of the children with the conduct disorder if the relatives has the conduct disorder or antisocial personality disorder, or if the relatives of the kids with ADHD use the substances, there is of course more chance of having ADHD kid or the kid with a disruptive behavior disorder. But there is no evidence of the serious structural brain problems in children with a conduct disorder and ADHD. And there is a minor brain dysfunction in ADHD kids. So what is the management of the ADHD disorder? The pharmacological treatment of ADHD consists of the use of the CNS stimulants, which include the methylphenidate. Methylphenidate is a drug of choice to treat the ADHD. Another drug is a dextroamphetamine, but since the amphetamines is legally prohibited, we are using the methylphenidate. So amphetamines, as you know, are also CNS stimulants. So it is used to treat the ADHD, but nowadays, since it is illegal, we are using the methylphenidate. Another drug which is also used to treat the ADHD is atomoxetine, which is a norepinephrine reuptake inhibitor, but norepinephrine reuptake inhibitor is not as efficient as the methylphenidate. So these CNS stimulants reduce the activity levels and increase the attention span and the ability to concentrate. And that's why the antidepressants may also be helpful. Like, for example, norepinephrine reuptake inhibitor is an antidepressant drug, which might be also helpful. Another type of psychiatric disorder which might occur is a Tourette disorder. Tourette disorder is a tic disorder characterized by involuntary movements and vocalization or tics that may include the involuntary use of profanity like coprolalia, while this behavior can be controlled briefly. Just a second, I'm sorry. I'm sorry, guys. So the Tourette disorder is a lifelong disorder, a chronic disorder. It begins before the age of 18. And it starts with a motor tic, with a facial grimacing, and then it turns to the vocalization. So this is involuntary involuntary motor tics. The person cannot control these motor tics and vocalization, and it is very disturbing to patient, this Tourette disorder. But there are some techniques that and interventions like behavioral techniques that teach Tourette kids how to influence on involuntary motor tics and vocalization. But well, it takes time to learn how to control this. So it is very difficult to control this involuntary motor tics and the vocalization. So this disorder is 3 times more common in males and has a very strong genetic component. So it is also a genetical disorder. And there is a comorbidity with Tourette disorder and ADHD and obsessive compulsive disorder. So these disorders can be associated with each other. So manifestation of Tourette disorder is behavioral. So we have these behavioral manifestations like motor tics and the vocalization, but the disorder, the etiology of the disorder is a neurological. It is believed that there is involved a dysfunctional regulation of the dopamine in the caudate nucleus. And because of that, antipsychotics are prescribed during the Tourette disorder. So these antipsychotics are really very helpful to manage these tics, like haloperidol or pimozid. These are the first generation antipsychotics which are applied to treat the Tourette disorder, as well as atypical agents like risperidone. Risperidone, as you know, is the second generation antipsychotic, and it is also used to treat the Tourette disorder. In milder cases, the alpha-2 adrenergic agonist agents such as clonidine can also be very helpful. But in severe cases, antipsychotics are prescribed to manage this disorder. Next is elimination disorders like enuresis and encopresis. So typically most children are bowel and bladder trained by the age of three. The elimination disorder, encopresis and enuresis, are not diagnosed until the age of 4 or 5. And after the medical factors like urinary tract infections are ruled, the most common cause of the enuresis is physiological immaturity. So how the most common type of the enuresis is the nighttime enuresis, and there is a very effective treatment of the nighttime enuresis, which includes the restricting the fluids after the dinner and the use of the bell and pad method or bell and pad apparatus. So what is the schema of using of the bell and pad method? The pad can sense the moisture and it is placed under the child at night, and if the pad becomes wet, the buzzer goes on and this wakens the child. So this method is based on the negative reinforcement, and after this negative reinforcement the child learns to wake up before the wetting at night. And besides this method, of course, we are using the drugs, pharmacological agents such as desmopressin, which is a synthetic analog of the antidiuretic hormone, or cyclic antidepressants such as imipramine. So both these medications reduce nocturnal urine output. But desmopressin is preferred because it has few adverse effects. So these methods are used to treat the nocturnal or nighttime enuresis mainly. So that's it for today, guys. And if you have questions, you can ask me. If not, let's finish for today. And only one lecture left next Monday. It will be in the morning also. So the very best of luck with your second midterm, guys. Do you have questions? Guys?
No, thank you, doctor. I think we're good.
Okay. So the best of luck with second midterm. I'm sure you all passed this second midterm on a very good scores.
Hopefully, doctor. Thank you. Sorry, I missed the
Okay.
first half
Bye.
of the.
Okay, bye-bye, guys.
Bye.
Goodbye.
Bye-bye.